Bom dia a todos. We are here and also we are transmitting for. Bom dia a todos, é um prazer a gente começar mais uma reunião da Retina. Hoje nós vamos contar com a presença do Dr. Carsten Mayer, que é alemão, mas mora na Suíça, trabalha na Suíça em Davos. E também a gente tem o prazer que ele é nosso professor afiliado aqui do Departamento de Oftalmologia. So thanks very much for coming. It's a pleasure to have you here. And we have Dr. Mayer here for this week, and we are seeing patients, and it's very nice to learn with you. Thank you very much.
Thank you very much, Kai.
And also we have online Dr. José Polido. He always is attending our meeting.
Okay. Thank you very much. Thank you. It was a warm welcome. And already had yesterday a very nice day in clinic where we discussed numerous cases, including macular holes. And I will give you a summary of how we can treat macular holes now and maybe in the future. And then I will also, it's not moving forward. Yes, then you can go. Also, okay. Okay. So I will talk with you a little bit about the changes of the vitreous, the consequences on the retina, and how we treat them. And then by the end, I will show you a couple of cases who needed a special treatment. As you all know, the cause for macular holes is mainly the vitreous. We have changes of the vitreous in younger ages, a very complex jelly formation with adhesions to the retina. And during aging, we have a liquefaction of the vitreous, which leads then to partial and hopefully complete vitreous detachment. You all know you can classify them in different stages, and we know that you have more firm adhesions at retinal vessels, the macula, and over the optic disc. I learned a lot about from Jerry Siebig, who was a frequent visitor at my previous university in Marburg. And you also know what is with pathological or incomplete vitreous detachment that can lead to numerous diseases, epiretinal membrane formation, or today we talk about macular holes. The evolution of macular holes have been first described by Don Guess by microscopy, and he showed us nicely how he was thinking at that time the macular holes derive. And he got a very nice confirmation later by Godric, who showed in vivo for the first time by the OCT how we see the evolution of macular holes and at which stage we intervene. And this led to numerous treatment options since more than 20 years. For the treatments, we know that vitrectomy is the treatment of choice for macular holes. And I learned a lot from Robert Markham during my fellowship at Duke. And later, we also learned that the staining of the vitreous plays a very critical role, where we had a very nice collaboration between Germany and Brazil in numerous studies over the past decades. Well, we were very amazed. This is just 20 years ago when we were starting macular hole surgery with ILM peeling. This was very, very new. And then we had first dyes available, which increased the visualization of the epiretinal membrane, and we could achieve a very nice macular hole closure. So the peeling with dyes was probably the right way to go. However, for a good anatomical closure. However, shortly afterwards, there were some concerns from the group in Munich, namely Christoph Harrituklo, who showed that if you do ILM peeling without dyes, you have better functional outcome than with the application of ICG. And when they stopped it, they reported again a better visual outcome. So yes, peeling is the right performance, but you have to be cautious when you apply vital dyes to the retinal surface. And when you don't use them in the right concentration, you can do harm to the retina because numerous dyes can be toxic. We formed a group with our friends here in Brazil, and we evaluated numerous vital dyes. Probably you know about them. And we concluded that we have now a number of approved vital dyes which you can apply to the retina and which really secures the retina from damages due to toxic effects of these dyes. We also wrote a second survey 5 years later in 2013 with more modern dyes and approved dyes that they are safe. And I think this was a big step forward for macular hole surgery to have a safe procedure and to make this really a standard procedure. So from 2000 to 2020, we got approved dyes. We know that we need a low concentration, short incubation, but in addition to the dyes, we also have improvements in our instrumentation. At that time, in 2000, we were still doing 20 gauge vitrectomies. Now we have small gauge vitrectomies, 25, 27 gauge, 23 gauge. We have better forceps, which don't bend, they're more stiffer. And so we have a really proper removal of these membranes. And we have also better light sources to visualize these membranes during surgery. So in my eyes, macular hole surgery has become our phaco search for vitreoretinal surgeons. It's a very standardized approach if you compare it to other retinal procedures. You do it very standardized. You do vitrectomy, posterior vitreous detachment, you do the ILM peeling, you do a gas insertion, similar to cataract, where you have also really well-defined steps to perform a safe phacoemulsification and implantation of an IOL. We have a very high success rate in both procedures and a very low complication rate. So when I started doing surgeries 25 years ago, there was still success rate of 65, 75%, whereas nowadays we are really in the high 80s to 90%, depending on the size of the macular holes. And in addition, in cataract surgery, we only have a very limited number of capsular ruptures where we have to intervene and do second procedures. So when I get a referral with a persisting macular hole, I always ask myself 3 questions. And yesterday we had one patient, I got an example where a macular hole persisted. So my first question is it the hole? So what is different is a hole? Is it a very old hole? Is it a very large hole? Is it idiopathic? Or is it, for example, a traumatic macular hole where you might have a different etiology and might expect a different prognosis of the closure? The second is the procedure itself. Sometimes I know the surgeon, and you know this, each surgeon has a different preference. What kind of dye does he use? What kind of forceps does he use? How extensive is his peeling? Or does he do a peeling at all? And then thirdly, the patient. So how was the postoperative period? Do we have did he maintain in a prone position? How was the gas fill? This plays a bigger role in Switzerland, where people tend to go back to the mountains and you sometimes can't fill it up with 100% gas fill because the gas is expensive at altitude and you will have a higher pressure. And looking at all these effects, I re-examined the OCT, what for example we did yesterday in the case where I said, well, the peeling looks fine, but on one side I see a hyper-reflective area on the retina surface. Maybe the peeling was a little bit incomplete. And if I see this, or even if I perform a second surgery, I would always recommend to restart with a restaining, because you will be amazed. Sometimes you can visualize membranes that were obscured during the first surgery, and especially if surgery was not done by yourself. Always convinced that the first surgery was a complete ILM peeling. If not, you can do an additional ILM peeling. And if, what we discussed also yesterday, if I do a second surgery, I want always to add something, because I think that most retina surgeons, they are very handsome and they do a good job. And why should I do a better job? Just with putting just gas in it. So I always look for something additive. So either I want to remove additional ILM, and if I do, I use this for an ILM flap. It can be sometimes easy because it was an incomplete or just a very narrow peeling around the macular hole. But if it's more extensive, then you can harvest also an RPE layer from the periphery and put it on top of the macular hole. So you are aware of this. So there are numerous techniques how you can close macular holes. In the first procedure, either here with a retracted door, or you can also use a free flap and put it under a decaline flap on top of the macular hole. It really depends at what stage do you do this in initial surgery in larger macular holes, or when you have persistent macular holes where you have to do additional peeling in the periphery. I try to harvest some ILM that I can put under the on top of the macular hole, because I'm convinced that ILM peeling is very helpful. ILM flap is very helpful to close macular holes. What are you going to do if you can't find any more ILM? And the fantasy is open, and numerous other membranes layers have been put on top of the retina. I'm not quite a fan, and I've done a couple of them, but I'm not really that convinced. So you can, for example, use the posterior capsule of the cataract, remove it. It's easy. You have easy access to it. You remove it, you put it on top of the macula. And yes, you see here the macular hole was larger. It's a little bit smaller, but what I want to have on my final OCT, I want to have a re-adhesion of retina to retina. And I don't want to stuff something in the macular hole, because anatomically you close the macular hole, but functionally you don't. So I don't think that capsule belongs on the retinal surface. And quite frankly, also with amnion membrane. An amnion membrane is very helpful. It can shrink and narrow the macular holes, but I've seen too many cases, like here on the right side, where you see that there's this hyperreflective material in the fovea, in the macular hole, and this doesn't belong there. And yes, you can call it the closure of the macular hole, but for me, you just did stuff something in there to close the macular holes, and also the functional results are not so convincing for me. Retina autograft, I know Tamer very well. The two of us, we were at Duke in our fellowship, and he's a close friend. But I'm not really convinced about his technique, and this is for really very large macular holes where probably you can do it. So this belongs to academic centers where you evaluate it, also with microperimetry and other techniques, which are not available currently to me in a private setting. So I don't do autografts in these patients currently, and I'm waiting for better evaluation of this very, elegant technique. And I'm looking forward to see if we can use this in an easier approach and implement for selected patients. But I think this is just a technique for really very large macular holes, which is not my topic today. So I'm really talking about the normal macular holes that come to your office. They are between 300 and 600, maybe 800 microns. And I think you don't have to do this very aggressive treatments to close the macular holes. So coming back to Jerry Seebeck, we know that the pathology of the development of macular holes is epiretinal. And I did show you that the release of all epiretinal membranes, vitreous, ILM, epiretinal membrane, will nowadays close nearly all macular holes, 95%. So I'm not quite convinced, why are we still putting something on top of the macula? Prior to OCT, this was essential because we were not really sure how was appealing. But nowadays, with good dyes, with good OCTs, we can be sure, did we really remove all epiretinal traction which caused the macular hole? And so the application of silicone oil, thrombocytes, or even ILM patch are one approach. But I was thinking we did forget something. So our hypothesis is that firm adhesions of the retina and the RPE might prevent the closure. Thus, the release of subretinal or application of subretinal fluid will release these adhesions, stretch the retina, and close persisting macular holes. Well, this idea is not new. As you can see here, it's more than 20 years ago. And this was a time when Mauricio Maya and I did our fellowship in the USC at Johns Hopkins and me at Duke. And that was a time of subretinal surgery trials. So we were really very convinced and developed techniques to approach the subretinal space. And I recall at one of the grant rounds, like here, we discussed where else we can apply this approach for other diseases, including macular holes. So Thomas Wolfensberger did it in Lausanne, and they presented it. But in 2000, if you look back at my first slides, this was a time we were really excited about OCT, new dyes. So we were predominantly only focusing on the epiretinal visualization and epiretinal membrane removal. And this was probably the right way at that stage. But somehow we forgot that also additional components might play a role. And so this technique got somehow forgotten. In 2011, there was one publication from Poland, but this was not done in a retina journal, so nobody paid attention. And it was 2017 when Mandelkorn described the technique again in a review in Retina and called it macular hydrodissection. So 15 years later, he described this technique. At the same time, from Canada, Roger Wong described a case series where he nicely showed that in persisting macular holes, 2 out of 17 remained open, but he could close with this technique the other 14 macular holes. But still, this was just a single center, a single surgeon technique, and it was still not so convincing. And I saw one of his videos at one of the meetings in Brazil. And when I returned, I saw ideal candidate. So this was an 80-year-old gentleman who had a 2-year persisting macular hole. He had chromovitrectomy with gas, extensive ILM peeling with silicone oil removal. And he was sitting there in front of me with 1400 microns. And he was really bothered by this scotoma in his central vision. And I got reminded from my fellowship, because in limited translocation, my duty was to measure how much you can drag downwards the retina, so how mobile is the retina. And this was 1600 microns. So I'm thinking, well, okay, this is a feasible technique even to close such eyes. I gave it a try, and I can show you here. This is a video, so this is still 20 gauge, so it's really an old video, but you can see it's a pretty straightforward technique because the eye is already vitrectomized. And I advise that early on, you put a little decaline bleb on top of the macula. Why? And I will show you later when you're really handsome how you can also do it without. Because, and you inject in the mid-periphery to the arcades fluid into the subretinal space, but you don't want too fast a connection to the macular hole because you really want expansion in the complete macular area before you close it. You can also, well, this was the early technique I used, use a scraper to close the macular hole, what Carl Claes recommended. But I don't think nowadays it's not necessary. If you have a good peeling, if you have released the retina, it's mobile enough to close even in large macular holes. Well, this was my first case. And I was amazed that 5 days after vitrectomy, I saw closure and a really normalized contour of the retinal surface. So I asked myself, well, was I just a lucky guy? Was this just a single case? So is this repeatable? Is this feasible? Is this, are the risks? What is the risk profile of it? And I evaluated it. And for example, here you see the autofluorescence, also, which I might point out how to inject the fluid into the subretinal space. So from translocation, I learned that we start injecting, so we start flushing the fluid while approaching the retina, so that in theory, the flow of the retina already dissects the nerve fibers, and then the jet goes right away under the retina, so that you have really only a pinpoint lesion of the RPE. I know that other guys, they really use a needle to poke through the retina into the subretinal space and then start injecting, which I think is a little bit more risky, as you might damage the RPE or even the choroid with some bleedings. When you do it more mechanically. So I prefer the flow of the jet. So we made a video and I presented it at video. Can you tone? I have a tone. Can you put up the tone?
Oh, yeah.
Speak.
You replace.
Yeah. Just one. Perfect.
It worked.
These studies and to so
Yeah.
if they are listening, so we can listen. Similarly, component your audio insieme audio considerando se
So that's a video, but if the rest listen to it, that's fine.
no
A novel approach using subretinal fluid may be more effective. It works by injecting fluid under the retina to release the subretinal adhesions between the photoreceptors and the adjacent RPE. First, a small decaline bleb is applied to cover the edges of the hole. Then, 3 small subretinal blebs of fluid are applied around the hole and the arcades in the macular area. The decaline bleb is now removed by shifting it over the optic disc and aspirating. More fluid is injected into the subretinal blebs, so they become confluent and finally connect with the macular hole. The retracted retina around the macular hole is now detached from the RPE. The elastic retina is now mobile and can shift and cover the anatomical area of the fovea again.
Wait, can you switch on my?
there you go.
Not even,
There you go.
Okay. So presenting this at a couple of meetings, I got reports from other colleagues who have also done this. Well, you see, this is just a rescue technique for persisting macular holes, and it's not done so frequently. But I was really keen. So what was the experience from other colleagues? So we collected more and more cases, and we wrote a first report on 41 cases with 12 surgeons from Germany evaluating the technique. Most of them use 3 subretinal blebs. They use BSS to apply in the subretinal space. What is very important, as I showed you in the video early on, that number one, you release the retina from the subretinal space, you stretch the retina, and in the end, you really want to release also the edges of the macular hole itself. Once you have detached the retina, this macular hole behaves like normal macular holes, so they will close within 5 to 7 days, and therefore gas tamponade is fine. In the early experience, some colleagues, they still used silicone oil. And here are the parameters of the macular hole. So the duration was 17 months, the aperture 1200 microns. And just keeps this number in mind, the closure rate was above 80%, here 85%, because this number will appear a couple of times. So our first study showed, yes, it's a feasible approach. As an experienced surgeon, it's easy to perform. There's a short learning curve, and there are no really big complications as we use subretinal needles in other diseases as well. With this in mind, we described the technique and evaluated. We compared it with other techniques like here from Carl Claes, but he tries to close the hole on the table, as he mentioned it, with a Tano scraper, and I think this is too much manipulation of the retina. In addition, I also don't like, and we discussed this yesterday, so my preferred application of the subretinal fluid is transretinal with a 41 gauge needle, because you can do it usually at the upper and lower arcades where you have a little bit thicker retina, where you have the nerve fibers. Others use an application of the fluid through the macular hole itself, but I think this can really damage the most sensitive photoreceptors around the macular hole. And also these functional results are not so convincing for me. So I show you here also a couple of other examples here. So numerous videos are available from Ruben, who showed this nice animation where you see how you do the ILM peeling. So he did this in a couple of trauma cases. You inject the fluid into the subretinal space, and then he prefers still in large macular holes also the epiretinal manipulation to narrow the macular hole, which I think is not essential. And I show you here an extensive video. Oh. Okay. Is it running? It's not running here.
Yes.
Here. So this is from my co-fellow Makoto from Japan. And you see, if you're really very experienced, you can do it without the PFC, but you can nicely see how now it's injecting. And once the bleb is approaching the macular hole, the resistance is too low so that the fluid continues to flow through the macular hole, and then you have to go to another area. That's what you want to avoid. If you're experienced enough, you just can go to other locations. But I want to show you this video what subretinal fluid application can mean, because some they just... Is it running? Yes. Okay. Maybe I move a little bit forward. So he's doing it in another quadrant. He's doing it repeatedly, and you see very gently he's injecting it into the subretinal space until it's really approaching what you see probably now. You have a connection to the macular hole, and then you can no longer expand it. And I think this can be a little bit difficult in your when you are not experienced enough with subretinal fluid application. You're not here to, we did a third lab here in the periphery. I'll show you here in the end what was very interesting. So he was injecting even more fluid into this. I think this is really very extensive. It was a large macular hole. You can apply quite a lot of fluid into the subretinal space. I try to avoid it through the macular hole because I don't want to damage with my flow the RPE under the foveola. So that would be my concern. But he did it very successful, and you see you can nicely absorb the subretinal fluid, do a fluid gas exchange, and then achieve a closure of the macular hole. But I think there's a very nice example, some that you just do it around the macular hole, and here you can, he's going even outside the arcades to detach the retina. So over the time, I got more and more reports from other colleagues. And as of today, we have 44 surgeons from more than 13 countries who submitted me their cases. So we have now 150 cases on file. And we see that, well, you see that the size is basically the same. The outer diameter, 1200 microns. Most of the surgeons use later a gas tamponade. And with more surgeons, we see that we can subdivide idiopathic and secondary macular holes. The preoperative parameters, they are also similar to our first study, close to 17 months. Visual acuity was similar, and also the outcome after 1 month, you see again a closure of 83%, so it's always above 80%. And we observed a similar gain in visual acuity in nearly 4 lines. With more patients now on file, we can subdivide it, because I think where I see the predominant indication of this surgery is idiopathic macular holes. And we had 119 idiopathic macular holes, and as expected, you will have a higher closure rate. So it's nearly too close to 90%, and secondary macular holes, as expected, was lower. But if you take a deeper look in the data, that the persisting macular holes, it was just a try to close them. 7 out of the 12 had a duration of more than 20 months. And 10 out of these eyes had a dimension of more than 1400 microns. So I think, yes, there's an upper limit of this technique. You cannot stretch the retina unlimited. And that's my duty my current duty to see which are the best indications for this technique. In secondary macular holes, we see that out of the 33 eyes, we had 12 with pathologic myopia, 12 after retinal detachment, trauma, or iatrogenic retinal macular holes, and also some vasculopathies, DME, RVO, and MAC10. So, but we still have a closure of 60% in the size. So evaluating this technique, you see that always above 80%. So with this technique, you will have a closure in 4 out of 5%. We have now 1 year follow-up results, and you see, as expected in the closed macular holes, a constant gain. And I think it's really essential, because we have a real closure. You don't stuff something in the macula, you have a real closure, and you can gain in the closed macular holes. You will find a mean gain of 4.5 gains, and as expected, a very limited gain in secondary macular holes due to their outcome. With these techniques now, we can combine them, and which we have done 2 years ago. So you can use epiretinal flat technique in combination with subretinal fluid application, where you can also achieve better outcomes. And what is very elegant now with the classification from Flavio, we are now capable really to subdivide and to compare our groups. So which technique is best for just an ILN peeling, for flap technique, for macular hydrodissection, and for additional techniques, namely amniomembrane or autologous retina transplantation. So my conclusion to this technique is that the evolution of macular holes derived from epiretinal membrane or vitreous formation. If you remove all epiretinal tractions, you will find a closure of more than 80%. In persisting macular holes, as we did yesterday, always look on the epiretinal surface are the remaining membranes and think about subretinal firmer adhesions. Subretinal hydrodissections will release these adhesions, stretch the retina, and close persisting macular holes. Well, now I talked a little bit about the large macular holes, and you also asked me to show you some additional cases where we did something different. So I show you here a case. A lady came to my office before Christmas. She had floaters. You see that incomplete vitreous detachment, syneresis of the vitreous, and she came 4 weeks later, just before Christmas. So her vision was declining. She also noticed some flashes. And right before New Year, I saw this vitreomacular traction and her vision was declining. What would you do? Nothing, wait. Come back next year. Okay, it was New Year, so they say, okay, come back next year. Yes. She came back next year, and you see vision is declining, you now see a lamellar hole. Wait, do something.
Right. Well,
She is.
let's do the normal thing here.
So
you make it here.
okay. So
Let's see.
Karsten, let's observe a little bit more.
No, just a second.
okay.
Let's see if it's not really a season.
Mhm.
And there is a partial PVT with declined vision. Can you hear what I'm saying?
Yes.
Okay. I mean the
Audience.
Okay. So would you do something different in that situation?
Mm-hmm.
Maybe inject a gas bubble or do a drinking bird maneuver, for example?
No.
No.
So I would say, you know, this, I mean, she was 35, so it was she was not myopic, but she noticed the floaters. And well, I think in her first visit, she was just concerned about the flashes.
Right. In a PVT like this, we should usually observe and not really make any intervention.
Yes.
Mainly if there is no signs of retina alterations in the OCT, but the retina was okay, or there was only the PVT and the retina was looking fine. The ellipsoid
So everything was fine.
So
Well, this
that's the way we should usually do.
So the question is, how is the other eye? For example, if
it's fine. I don't have the pictures. Excellent. Excellent.
You see the patient had already a macular hole on the other eye.
She developed now.
But
To make the long story short, and I can show you the pictures a little bit later. But for me, it's you said at this stage a lamellar hole with a declined vision, but she's young. You would now go into surgery.
yes, right.
What other choices do you have?
Observe, gas bubble, or interact.
Okay. So suddenly, and what would you do now? She comes back 2 weeks later, and now you see she has now not a lamellar hole, but a very narrow but full thickness macular hole.
I think now it allows for reflection.
Well, I learned this actually from Gustavo because we wrote a paper on mini macular holes. They still can close by themselves. And she was 35, so I said, when I do a vitrectomy, I can induce cataract.
What is the minimum macro hole? Maximum 400 or 200?
100 microns. So this was just on the border. And actually this continues. So she has 2400 vision acuity, small macular hole. What would you do?
I would do guess.
Karsten, are you hearing me, my friend?
Yes, I hear you.
Oh, that's great. Actually, in this case, I agree with you. There is a possibility of spontaneous closure around, if I'm not wrong, around until 10%. Okay, but as you're observing the patient, the vision is going down, etc., etc., etc. I would go to surgery because it's a very safe procedure, and we can do it with a chromovitrectomy. We can double check the periphery of the patient, and I think it's the best thing to do at this moment, at least in my hands.
Another option would be just a guess with the drinking bird maneuver. That would be another option. That's not really.
So
Yes,
Very good success also.
So
this is an option. This is an option, Michelle. But I'm a little bit afraid of young patients that you may induce a tear in the periphery of the retina. I prefer go to the vitrectomy nowadays.
well, I agree with Michelle, and I gave actually an air injection. 0.1, just air.
Just 0.1.
Yes,
0.1.
The OCT is 24 hours after air. Well, I said to her, I don't have it here.
This is the volume you choose when you trust that. I usually do 0.2. So
yes.
I don't know if
Well, you have to compress it. So I think it was probably 0.2, but I think it's really hard to dose with gas into a non-vitrectomized eye, because early on you compress the syringe, and before the gas really goes in, it takes a little time. So it was 0.1, 0.15, whatever. And so for me, I make a difference. And Mauricio, maybe also I'll ask you for your experience. This is very successful in young patients, because I think it's just a prolonged induction of the posterior vitreous detachment, which you might find in younger patients. And we know this from microplasmin. Microplasmin was working in young patients very well, because I think that it's not so firmly attached. And from surgery, we know that in elderly patients, when this lady would be 70, it's much firmer. And you know this from vitrectomy. Sometimes you really have to pull, and probably a gas injection or air injection wouldn't help. So in this patient, I was really lucky.
But just 1 second, please. It also depends, let's see your opinion, on the extension of the adhesion.
Yes, so the size.
If it's a plateau, then probably I wouldn't do it.
Yeah, if it's
But if it's just a point at the end, then I think it makes more sense.
so. I just selected this case because here I was really lucky, and we have now quite a bunch of patients. So in young patients, when you see vitreomacular traction or even a macular hole formation, you see that after a release of the vitreous, you can have a closure of even a full thickness macular hole, and 1 month afterwards, even a full visual recovery. I agree with Mauricio that you have to pay attention to the periphery, that there are no tears, and even prior to the injection, to pay attention. When I gave the injections, I told the lady to be really not to sit at home, but to be moving. She should listen to music. So she selected Metallica with her son. And so that was very helpful.
Well, if the retina is fine, there is nothing, there is no lens, there is no tear, etc. It's okay to do that. But if there is a tear, it's not okay. But if there is just lenses with no holes, so this is another possibility.
Yeah. Well, because but I would have very short intervals. What I learned here is either you have a detachment within the first 5 days, or then I would go into surgery. Anyway, so I would still do, because I have an option to maintain a crystal clear lens and to avoid surgery early on. So I would give an injection. If this is not working, I would go into surgery. If I would detect a hole, then you anyway have to combine.
Time you would wait to see if it was a successful procedure with people guess and the maneuver, the movement.
Yeah.
Would be maximum 2 weeks, and then if it's not working, then
Yes.
2
So I
weeks
think
or less.
probably even less, because even
the
if I inject some otherwise SF6 bubble, and probably once the bubble is gone, you don't have any therapeutic. So either it was effective and it was really going under the vitreous to detach it, or you're not successful.
And why do you choose SF6 and not C3F8 for this situation?
Because usually you use SF6 in these, for subretinal, just as a solid injection. So undiluted.
The time that if you have success, going to be in the first or second day. Otherwise,
I think it's you just. I agree. So you just have to kick it a little bit that it releases. And so.
But there is any problem if we do C3F8?
No.
Okay.
do you have any, for this kind of procedure, do you have any criteria like for age, size of the macula hole?
Small focal adhesion, agree. Better prognosis in younger patients, but they are also preferable due to the clear lens. When you have a 75 pseudophakic, doesn't, probably I'm also more on the vitrectomy side, but here it was also, the purpose was to maintain in the young patients with still accommodation, and she was really thankful that I didn't do, just do vitrectomy and be done with it, and then you need you get pseudophakic and you need reading glasses or whatever. So she was really helpful. Now I'm going to show you the opposite. So where can you do surgery? So I have 2 other cases. It starts actually also again with my fellowship, where I work with Cindy Toast on new mechanisms to induce RPE tears, and she came up also that vitreous traction can induce RPE tears. And when I returned to Germany, that was beginning of OCT. You see here a patient, see on the left eye, this appeared really unremarkable, but his vision was really declined. And on OCT, you see here that there was an occult macular hole as well, in addition to AMD. So in Switzerland, I saw this gentleman here with fibrovascular PED. On OCT, you can see here the PED, but also firm adhesions of the vitreous on the retinal surface. This patient got this normal uploading phase, firstly with Lucentis, the PED flattened. We continued with Eylea, so vision improved. So the case looked pretty normal. And over the years, we could treat and extend it to 7 weeks, 8 weeks, vision of 20/40. And after 8 years, you see then, or 5 years, you see now a disease progression with additional subretinal fluid. So we had to reduce the intervals again, 6 weeks. It was going away, but there was still some intraretinal fluid. And you still see this firm epiretinal adhesion. So it's now 6 years under treatment, and with all these injections, you have also liquefaction of the vitreous. So you see a PED, you see this traction, and you see there's some subretinal fluid.
So let's stop for a moment.
Yes, so what would you do now? Just continue injecting?
Well, this, I'm pretty sure that, almost sure, let me say, that the traction has a hole here. The PVT, partial PVT is maybe a factor that is avoiding the stability of the treatment. And then maybe
Very good.
to have a PVT, which is another stimuli that you don't want in this situation, may be released, and although the vitreous is a reservoir for the medicine, remove the traction, but not removing all the vitreous, not trying to do a big extensive vitrectomy, but just a core vitrectomy to release. And then that would be an option to get rid of this factor and not get completely rid of the reservoir.
Okay. Well, let me switch a little bit further, but I completely agree. And well, in normal, just not with a PED, but sometimes when I see that you give numerous injections in AMD patients and you really can't extend it over 6-8 weeks. I look at the OCT, and when you have firm adhesions, we discussed it, and I leave on purpose the air in the syringe and then inject it with it. And sometimes after 3 injections, the vitreous pops off and suddenly you can expand it to 10-12 weeks. So I exactly agree that it's not the cause of AMD, but it's an additional stimulus that might prevent an expansion of the duration.
So then you inject air.
Yeah, I just leave it in the air which is in the ILEA syringe. So we
Right, that would be how much? Like 0.1?
Yeah.
0.05
and these and these elderly patients, they don't listen to Metallica.
Put some SFCs and also the anti-VEGF.
Yeah, so that's another. Well, this patient got additional treatments, and after the last treatment, she came back with suddenly hazy view. The fellow presumed, oh, well, it's probably a release now of the vitreous and there's some opacification.
Lens opacification.
And I said, like you, show me the same scan, because what you see here, this is a horizontal, and all the other scans were the vertical. Say, show me the vertical.
I would like to see the corner too.
And this is the vertical.
Because sometimes the corner gets real bad.
Yes. So this is the vertical scan. So it was not a presumed release of the vitreous. Now you have a macular hole.
Yeah.
So what over a PED? The question is, can you peel a macular hole on top of a PED, or can you induce a rip? And what would you do? So what you do in this weight, SF6?
So there is no more partial vitreous detachment.
Well, no, it's still attached.
Is it
So I
still
showed-
attached?
So I showed you here. This was 8 days later. Macular hole is increasing.
So now we have no other choice. Yes.
You're brave. You already would. I wait another 10 weeks. So vitreous is still attached. So you have now a macular hole of 370 microns on top of a PD. How would you
Well, the
prepare?
PET is flat. It's a little bit flatter.
It is, but it's still present.
Still
So
flat.
can you? And then the question is, well, what would you perform?
I think that this PET doesn't avoid the surgery.
But would you just induce a PVD, or would you do an additional ILM peeling?
Oh,
Is it necessary in this size? I mean, it was
well,
only enlarging.
the size is, the case is getting worse. And the hole is getting bigger.
And
The PET is getting better.
yes,
So I think the whole is the main thing is increasing, and then I would go for surgery.
I agree with you. You know what I did prior to that, I did one thing because I want to stabilize the fibrovascular component. I did an additional anti-VEGF, really to calm it down. I don't want to have a rupture or bleeding or something else, because you have two enemies on top of the retina and below, and to influence, to stabilize the retina that is also more compact. And then I performed vitrectomy, and once you're in and you could nicely stain the ILM, I also peeled the ILM. And this is a picture a week afterwards, 2 months afterwards. So and you have a nice improvement of the visual acuity. So, but for me, the take-home message, yes, you can peel epiretinal membrane on top of a PED with a good gain of the visual acuity. And we published this case, and then I recorded, I said, oh, we had a similar case one of my last days in Bonn, where we saw something similar during the uploading phase. So you had a PD, I gave an injection, and then suddenly after the third injection, you had this macular hole. I also did a vitrectomy with ILM peeling. It's closed, but this was now 13 years ago, and they have in Bonn a really very good post-operative evaluation, and they can show you now the prognosis of ILM peeling or closure of a macular hole on top of a macular hole. So you see here the evolution. You see also in this case a wonderful visual improvement. So it's worth to do it. Over here, 6 years to 2040, you have to continue to give injections. Because yes, and you see over the years a modeling of the PED, but it stays basically in the same area. And here you see even after 8, 10, or 11 years, you even can see here the edges of my peeling. So it's still visible, but the retina thickness remains the same. So for me, yes, you can close a macular hole on top of a PED, and you can gain good visual acuity, and it's not something to be afraid of. So we looked at the literature. There have been just 10 cases published, and there's just one publication from J. Duca where it didn't close and they showed no improvement, but the others showed a nice closure and a good gain of the visual acuity. So for me, the take-home message is, yes, we can peel epiretinal membrane even or macular hole formation on top of a PED without a extensive risk of inducing an RPED or subretinal hemorrhage. What I recommend that you don't really detach the vitreous over the macular hole. So really, I detach firstly the vitreous at the optic nerve, and then I trimmed it very gently backwards, so not inducing too much traction. So it's a little bit delicate.
You use more tangential traction instead of anterior.
Yes. Yes, so you don't go in and aspirate it and lift it.
But the tangential will not be probably also completely possible. Will be like oblique.
Yes.
Marcelo, can I go back on this case? I tried with J. The one that you said it was not didn't move.
I know.
Because the patient they have much of the
okay. So I looked at the literature, but it's no expert here. Yeah. So, but I think it's really worth to try it. And I was concerned because I was thinking that if the vitreous can induce RPE tears, that vigorous manipulation during surgery can do it as well. So the take-home message here is, yes, we can form vitrectomy in PEDs without subretinal bleedings. Should be done very gently. You can do it in addition with ILM peeling. Prior anti-VEGF you can apply just to calm down the retina. And anatomically you have a nice reconstruction of the retina, but under the retina you have to maintain giving injections. So this long-term patient that I have, we perform these injections over 12 years now. And the patient I did in Switzerland is still also under control, but she needs every 6 weeks an injection. Again, because we don't have vitreous, we don't have a sponge that maintains the anti-VEGF. And we switch her now to the Eylea HD, so the high dose concentrations will probably maintain a little bit longer in the vitreous cavity.
Guys, what would be your thoughts about the size or volume of the PET? Because, okay, you can do it in patient with PET, but it depends on the size or volume of the PET or not. So this is one study. Okay. But for example, if you have a PET higher than 600 microns, then that would be the same, no problem. So you can do the surgery or this.
Now, if that's really hard to say. I mean, for me, even in macular holes up to 300 microns, you can close it, which is also, you know, we talked about subretinal fluid application due to other entities in the subretinal space that have an effect on the closure rate. So PD appears not to have a big influence on it, but there's probably even an upper limit. So if you have this, but I've hardly seen it in larger macular holes of 600 or even larger. So I think they're more smaller. But it's also very easy overlooked. So people say, oh, they just have a PED and they have a disease progression, inject. So you really must, if the PED looks the same and you have a decline in visual acuity, also look for other possibilities. As I showed you here, horizontal, vertical, OCT, suddenly see, oh, something second happened, and this was the reason why his vision declined. And after vitrectomy, vision went to the same level like the treatments with just of the PD itself. So you can restore it up to that level. So this was a little bit potpourri to macular holes, large macular holes, small macular holes, without surgery, with gas, and with AMD as well. Thank you very much.
Thank you. I have a good practice.
Yes, sure.
So for the technique that you created, the strategy you created doing the retina holes around the macro hole, the smallest hole that you did was 1.4, right? For this technique.
1.4?
Well, 1,400 micro.
Yes.
This was the smallest, and 2.7 to 2,700 was the biggest.
No, we have even more than 3,000. I got
More than 3,000. So
But
because I saw the numbers.
yeah. So I got referrals for larger holes. So I think that it's a good technique for our normal holes, like from 400, 800 microns up to 1,000 microns. You can use it, and I just want to calculate how the prognosis is going down if you're above 1,200 microns. But there's probably a limitation of this technique, because you can only, it depends how much retina you liberate and how elastic the retina is.
What I would like to know, what is your turning points when you have a macular hole? When you decide to do a normal technique with just the internal and billing, and when you decide to change for the technique that you just described with the
I usually okay. Well, I usually use this as a rescue technique. So it's in my first technique.
So was already operated.
Yes, I do it in my normal vitrectomy is up to 400-500 just ILM peeling, and the second is with an ILM flap, And yesterday we had a case, either if there's no ILM left, or I think that, you know, I said in my first talk that if I get a referral with persisting macular hole, I have to do something in addition to the previous surgeon, because I think he did already a good job with the peeling. Why it should just be fluid gas exchange, close it? So what kind of options do I have? You can do a more extensive peeling. You can put a flap on it. And if this is not present anymore, then I would go for subretinal fluid. So, but it's more for me, therefore we only have 150 cases. And most surgeons use this as a rescue and as a third surgery when other epiretinal approaches are not working. And even I had the other day a conversation with Klaus Eckert where he also said, I have a macular hole, didn't close for, I don't know, 3 surgeries. And he was thinking about either doing the subretinal fluid or from Marta from Spain to use thrombocytes. But then also in private office, in university, it might be easier. In Switzerland, it's horrible to obtain it because you have to go to numerous administration to obtain it. And therefore, my idea is when I have to reoperate it, I would use a subretinal fluid approach because it's, as I showed you, it's very fast, it's very easy, and we have done it. We do it in subretinal bleeding, so it's nothing. They said, "Oh, this is completely new for me," and it's basically 5 minutes procedure. It's very easy. You have a vitrectomized eye, and you go in, you detach the retina, you do a fluid gas exchange, and you're done with it, and you put the patient in the prone position.
You know, there is another option to do the surgery for the big macular holes that almost nobody talks. That is, you mentioned extended IM billing, but how extends? Usually, when I do not do any of these techniques, I do just IM billing. With this, when the hole is from 1,000 to 1,500, this big hole. I am billing from arcade to arcade, so it's big. It usually works as well. So I don't know if you have the position.
I've seen it. I've seen a couple of cases last year in Egypt where they also, but then they use with ILM flap technique, but they use them even multiple layers.
Yeah,
I don't know whether
without
this,
that, without that,
but this is, well, you know, I would make an extensive peeling without using, because I think the flap has some additional benefit.
yeah.
Because for me, the point is how much should I peel to maintain something for a flap? And so should I do an extensive peeling? Because if this is not working, I don't have any more ILM left. I agree with you, in large holes, you have to do it more extensive, whatever you do. And in really larger holes, I would tend to do also a larger peeling, but I would already use the liberated ILM to flip it over just to
have more,
and
one
yeah,
more addition.
so I just had one the other week, it was 800. So I said 800 just in ILM peeling could be difficult. I use it, I flip it over, and well, I was lucky. It also closed in the first procedure.
I will bring some cases in the future in the meeting here, showing that cases when you were kids working without internal intent membrane over the hole, you also can close.
But what would you do if it's not closing?
So that's the problem. Then I can use other things instead of ILM. But that's cases bad. So that's right. That's it.
But
Marina?
Maybe something how much volume or maximum volume of PSS injection?
well, I usually tend to do 3 subretinal blebs, and that's what I learned from Cindy Toes. You approach the subretinal space. The best is the firmest or the strongest retina you have close to the arcades because they have more nerve fibers, and then you go with more nerve fibers, and then you detach it. So you lower the infusion bottle, you inject it. So for me, the detachment of the retina, it's not a volume thing, it's more the extension of the detachment of the retina, I would say from arcade to arcade, roughly. So, and if you do this predominantly, you can do it with 3 subretinal blebs, one in the upper, one in the lower, one in the temporal. And but I've seen unsuccessful cases where I realized, looking at the videos, that they detach. So number one, the extension plays a role, and I like when it's a little bit more bulbous because you stretch a little bit to liberate more tissue to close the macular hole. And in addition to that, in the end, you must really, that can be very, sometimes the firmest adhesions are just at the macular hole itself. And I've seen cases where they detach the retina, but not the macular hole itself, and then the fluid went away and the macular hole didn't close, because there were the firmest adhesions. But I try to at least to avoid, but I don't like, some people, they inject also viscoelastics and through the macular hole. But there you have for me, the most delicate photoreceptors are at the edges of the photos. You want to narrow these, and I don't want to touch them. So therefore I go more transretinal and not through the macular hole into the periphery, because I think just to preserve vision, it's easier, or it's better that you go transretinal, you do it arcade to arcade, and then do a fluid gas exchange.
Well, let's see, just answering your question a little better. If I do it extensive internal independent cleaning, and the macular hole doesn't close, then from where and what should I use to close the macular hole instead? There is a few possibilities. Internal independent membrane from other area. That's not the macula. You can remove it from the nasal side or from an area, and then go to the macula, or the whole thickness of retina without being the detail, of course, and bring it to the macula. So have you tried this?
No, but I know this autologous transplantation from Tema, and the two of us, we were at Duke at that time, and yeah, you probably can do this in an academic setting, but in the peripheral hospital, it's.
But the internal limited membrane, remove it from the other side.
I've tried this as well, but in my eyes, but it can be also quite just difficult. So for me, the easier approach is to go underneath, and our number set, 4 out of 5 is going to close with it. So
yes,
for me, this is a easier approach, and you focus a component that is not touched by any of the other techniques, because you're just manipulating the apparatus surface. You remove the membrane, you remove remaining membranes, and so on. But if this is really smooth, 15 years ago, this was an issue. We didn't have good dyes, we didn't have good OCTs, but nowadays you really see the epiretinal membrane is smooth, so there is no traction anymore, and it should close. If it's not closing, then where's the resistance? And I was amazed in how many cases just to release the photoreceptors, that the elasticity of the retina, so they behave normal. It's not a slower closure. So these holes close within 5 days. So it's the elasticity of the retina is there. If this is still present, they can close within 5 days, like a normal.
yes, we understood that you mentioned that you do not recommend that when we detach the retina with subretinal BSS, that the fluid shouldn't escape from the subretinal escape through the macula hole.
Not too fast, because it prevents the expansion of the retina.
Right, but if during the first injection,
Mhm.
it already happens. If the fluid went to the macular hole, and what should we do then after this situation?
I showed in the video. Therefore, I apply a little decaline blend on top of the macular hole. Yeah, so you see, and I showed you the video from Makoto. If you really experience it, you can play with it a little bit. You're more experienced. But if you do it for the first time, it's easier because once you have this access, you can no longer use this site, then you have to go to another site. It's much easier. Just fix the macular hole as a third hand.
Use the carbon.
Yeah, just a little
Just a
blab.
little bit.
Yeah, and detach the retina, then remove it and inject one more time fluid so that the retina completely detached, but you don't want to have this initially early on. So you want firstly to detach and to spread it, and then you have the detachment of the macular hole.
So, I know we're talking about big macular holes, but have you seen many microperimetry changes in those area of subretinal detachment? Have you studied something like that?
No, I don't.
After the reabsorption.
But we know this from limited translocation. So what I also changed is the, the fluid from macular translocation. We use the BSS plus without the small bottles, the plus, what Peter Wiedemann showed very nicely. You have an easier detachment and you have less trauma to the photoreceptors. But in limited translocation, also parafoveal, you didn't have their changes. And the visual acuity says also, and you see this, if you have a short detachment in retinal detachments in RD, you have a good recovery. And these are younger patients, so I don't have microperimetry available, but I think that the trauma detaching the retina is quite limited. And you see this sometimes when you have a short duration of retinal detachment, you still can have very good visual outcome.
But the problem when we do the limited translocation, the reason to do that was age-related macular degeneration.
Yeah, you want to.
So it was the macula was not so easy to detach.
This was more fun. That's right.
That
was a gene.
Yeah, we did several limited macular translocation that the macula sometimes didn't really detach because there was some scar tissue already,
Yes.
fibrin, etc. But then you have to another orthosis. Macular hole is easier to detach the retina then in the situation that you have the age-related macular degeneration.
That's the case presentation.
That's
a case. That's
presentation.
Karsten,
Yes.
may I ask you a question, my friend?
You already did, so let's go for the next one.
Okay,
This is a question.
so I'm very glad. I'm very happy. I'm very happy that you talked to us today about the holes they close with the conventional technique for the bench. A lot of alternative techniques may times cause a confusion what to do, but what we have to do is the most simple patient and technique of ILM clean and the gas because it works in vast majority of cases. So I think this is the most important point, in more opinion, that you brought here for us. But my question for you is that when we have a special case that's did not seal, and we do the option of subretinal fluid, as you showed very elegant, this elegant technique. I had the opportunity to do some cases, and it really works I would like to know your experience about the outer retina of these patients, because you have now more than a year of experience, and we know that these patients may improve the outer retina layers and improve also vision for more than 1 year. Could you share with us what your experience when you do this technique about the functional outcomes and the outer retina healing process when we do subretinal fluid injection?
Yes, that's an excellent question. And well, I showed you functionally that by a year's time, we have a gain of 4.9 lines, so nearly 5 lines. So once you have a post retina by retina, you can have a really nice gain in visual acuity, and 4.5 lines is a mean gain. So you have even better functional outcomes. And to your question regarding the outer retinal structure, I have from 50 patients post-operative OCT scans, and we are currently evaluating in Munich and compare it macular hole closure patterns and also the ISOS layers in the retina after either ILM patch or subretinal fluid. So we are currently working on this, but the changes are minimal, and the longer the more they are out. So it's really hard to see there any difference. I was amazed because I assumed that doing one or the other technique, they're just opposite. On the one side, you do something on the retina, and the other technique, you do something under the retina. But the healing process and after the closure of the macular holes, the OCTs, you can't see a difference in the pattern of the OCT. So once you have a post, what is your experience? I think it's more you want to have a closure of the macular hole, and then you have a healing of the photoreceptors, but the healing that in the end you have a similar outcome. Or do you see after ILM or after ILM flap some difference in the OCT?
I think.
Okay, so
I think that
so the
when you test the retina, the problems in the microperimetry happens when you touch with the forceps, when you do things like this is a trauma, related problem.
To the nerve fibers on the top of them. If you grab too deep in with your forceps.
So in your experience for long term, the ellipsoid zone is in a good shape. That's
yes.
it.
Yes,
Okay.
it's in a good shape
That's
because
great.
you just have a very short detachment. So, and that's the experience we have also in retina detachment. So if you have a very short detachment, you can have excellent functional outcome in nowadays. And here you have a detachment of literally minutes or hours or whatever. So so I think that the outer segments, they regrow, and the functional results show good results, and therefore you have a good recovery of the photoreceptors.
Very good. Thanks a lot, because I did only 4 or 5 cases, I believe, and there is not many cases to have a conclusion. That's a very interesting observation. Thank you.
Send me your OCT pictures so I can add them, because in Munich we just comparing, because they have a huge file with macular hole closures after ILM patches. And now I just sent them my cases, and we really want to compare them if there's a difference in the structure after the closure of the macular hole in the outer photoreceptors.
Okay.
Very nice.
Okay, I'll do that. Thank you.
Let's do a case presentation.
Good morning, everyone. My name is Arnaldo Rosenblatt. I'm third year resident. I'll present the clinical case. So the case begins with a female patient, 33 years old, born and raised in São Paulo. Her main complaint is of metamorphosis since March 2023, progressing to a central scotoma. Her personal history involves hypertension and gestational diabetes. She has a negative ophthalmologic history, also negative family history, and she uses only metformin as continuous medication. Her ophthalmological exam, she has the best corrected visual acuity for her right eye of 20/125, and in her left eye, she's 20/20. Her slit lamp examination, she has clear conjunctiva, clear cornea, atrophic iris, no new vessels were seen. She has a deep anterior chamber, no anterior chamber reaction, and clear lens. Her IOP is 16 and 14, measured on the Goldman tonometry, and her fundoscopy will be shown on the next images. So here we have in this retinography on her left eye, we have pink optic disc with sharp margins, cut to disc ratio approximately of 0.2 on the fundus biomicroscopy. We have this yellowish lesion on the perifoveolar, approximately of half disc diameter. And on the rest of the indirect fundoscopy, we could see that she had an attached retina and no other vessels or macular alterations. On her left eye, her exam is absolutely unremarkable. She has a pink optic disc with sharp margins, symmetrical cut to disc ratio, no macular or vascular alterations, and attached retina all over. So initially for the diagnostic hypothesis. Okay.
Is she pregnant?
No, she's not.
We have a young woman, 33 years old, with separation of the macular of the right eye. We're thinking about some new vascular retraining, right? It's thinking about this a little bit for vascular columns. One of which is mental type 1/6 only the right eye. You'll see the left eye. But as she's not the scar infection disease, I see this tuberculosis. And I wouldn't think about polypoid disease, see the barrier, and see other things. Another cause is maybe polypoid induced stable service. That's it. Anything else?
After I saw radiation appearance of the network.
I think it was perfect.
Yeah.
I thought about, yeah.
Maybe best. But for the right eye. Can include all that.
Can go on.
So amendments. Clear. Or what's the next step? Measures.
So I would like to rest for city, water sense and geography. And I think that's maybe all fluorescence. Some.
Okay. So for the diagnostic hypothesis,
When we ask about other exams, we have to think what do they can help us.
Yes.
For example, autofluorescence in this equation. What would you expect to help? There's no problem to order.
I
Then you
think
have the autofluorescence, and then what's your?
I think the fundus autofluorescence would help us topograph the lesion if it's affecting more the RPE or it's more in from disease from a more internal retina, I guess.
Or if it has the best disease.
Yes.
As a hypothesis, since you have the autofluorescence, you're gonna see a hyper autofluorescence.
Yeah.
Right? If you have a Vitreous material positive.
Yes. So our diagnostic hypotheses at the beginning were, of course, infectious. We had to exclude blunt trauma with choroidal neovascularization secondary to it. Inflammatory autoimmune diseases, vitelliform, Best dystrophies, white dot syndromes, vascular, although not typical polypoidal, was initially considered. Macular telangiectasies, or an idiopathic subretinal membrane, or even tumors, melanoma, gliomas. So we asked for complementary exams. Here we have the infrared of the right eye, where we can see the previous lesion, the margins of the previous lesion, but with hyper signal smaller lesion around the fovea on this patient. On the left eye was absolutely unremarkable. This white dot at the center of the image is an artifact. On the red free, we can see some dots with hypo signal and a ring around the fovea with hyper signal. Also on the nasal to the optic disc, we can see some hyper signaling dots with some hyposignaling dots in the middle. On the left eye, we thought initially that the exam was unremarkable. On the fluorescein angiography, I'll first pass through all phases, then I'll comment those. So on the right eye, we can see some leakage on the periphery, but that's not related. We thought to the pathology. We were sorry.
It's not a leakage. It's a hyperfluorescence.
This
Okay, it's this point.
yeah, and we thought they were non-significant, but we would expect more vascular meshwork on this periphery.
There is no perfusion area.
Yeah.
It's a hypofluorescence.
Due to non-perfusion, yes. Centrally, we can see again our lesion with hyperfluorescence due to leakage on the most central part, and on the periphery of this hyperfluorescence, we can see some hypofluorescence due to blockage. Also, we can see some small leaking dots, perifoveolar on the right eye. On the left eye, initially, we thought the exam was unremarkable, but here we'll again see the correlation of this small white dot on the OCT of this patient. But otherwise, her exam is absolutely unremarkable. On her OCT, we can see this hyper-reflective material under the foveum, also with serous retinal detachment on the borders of this lesion. Otherwise, the internal and external layers of the retina they seem healthy, but the external layers under the fovea are affected by the pathology that we are investigating currently. Here, a more amplified image from her OCT, where we can see mainly some fluid between the inner and the outer retina. And here on her left side, we can see these small beads under her RPE, and that makes us think of more of a pathology than the others we were asking ourselves. Here, an amplified image of that small choroidal excavation. Small choroidal excavation. Thank you.
So now, Juliana, that you asked the exams. So
there's still the OCTA, sorry. Can I show the OCTA or, okay.
The OCTAs.
Yeah, we can see the membrane here on the OCTA with the correlation map, and unremarkable on her left side. That was all the complementary exams we had.
So now,
Sorry.
Please. Yeah.
The membrane.
Yeah.
Yeah, would be here on the outer retina and paracapillaries also.
So you can leave this slide because this is the main finding. Right?
Yes.
Now, Juliana, that you have all exams. What is your hypothesis? What would you do?
Because of the left eye, the OCT of the left eye, I would think about Martel disease, because it's temporal to the fovea, and you can see the retina, the internal retina, like falling down to the external retina that doesn't exist anymore. And the right eye, you have retinal neurovascular membrane, secondary to the geometral.
So your diagnosis might have some membrane, it's a subretinal membrane to Martel.
Yeah, but I think about this diagnosis because of the left eye, because I think the right eye, the disease is so advanced that it's harder to say it's Martel.
The first is live presentation. The first.
The retinography.
Yeah. So looking ophthalmoscopically or biomicroscopically, would you think about Martel now? Just with this situation would be part of the differential diagnosis, right?
What about the confusion area in the periphery that's for our attention? Why there's that area of the confusion? It's not less.
Wouldn't be secondary to Martel, but
There is tension, there's around on the right eye.
Peripherally, to the points that you showed, as with the hyperfluorescence, that you said leakage, but there is the B points also in the periphery.
Oh, those would be the telangiectasia.
Yeah, it would be interesting to see OCTA in this area too. I don't know if you can
Yeah.
go up to
Yeah.
too far.
Yeah, would be hard to.
I think it's.
Ô, Arnaldo,
Listen.
Yes.
bom dia. Tudo bem? A discussão, mas você está achando que seria a Mactel do tipo 1 ou do tipo 2?
Por conta, may I answer in
Oh, sorry, in English. Sorry.
due to the being bilateral and mostly acquired, according to her main complaint, we thought, although really asymmetrical, we thought about Mactel type 2, but on different stages, of course, between both eyes.
On the left eye, looks good for
I don't agree with this diagnosis.
So,
I think it's probably another case of peak,
Yes.
and the
Oh,
left
Yeah.
is a hilate lesion of peak. A peak. I
Yes.
think it was inflammatory or neovascular in the left eye, but you don't have anything from Excel to.
Yes, I agree with Rodrigo, Arnaldo. I don't think this is a Mactel. The case doesn't show the characteristic findings of Mactel. For me, this is a type 2 CNV due to either an infectious disease or inflammatory disease.
Luis, Peter, what would you think about the peripheral lesions, the hyperfluorescence lesions? What are they?
Yes, I think this patient has like MFC, multifocal choroiditis, and has this CNV, MFC related lesion in the macula. So I think we have to further investigate the causes. Luis mentioned infectious, we have to rule out, but he has like MFC with CNV in the macula. It's not very usual.
Yes.
It's more common in peak lesions. But once he has this peripheral alterations, he also has some nasal changes outside the arcades for classification purpose. We would probably consider this a MFC patient and not a peak lesion. Peak lesions are only confined to the between arcades and macular region.
And also,
Yes.
if you go to
And-
OCT on the right eye, you see this hyper refractive area, and this is like choroidal vascularization due to inflammatory agents. It's much more likely to due to inflammatory.
I think also there is this aspect, this group remembers me vibrant this location as well.
Yes. It might be fibrin or sympathetic form.
Yes. It could be also a hyperreflective material similar to the vitelliform, because in the retinography we have yellow respond to the vitelliform lesion. This case. Could you show again the autofluorescence of this case, of this eye, the right eye, please?
I think we didn't show.
We only
infrared.
yeah.
We don't have the autofluorescence, just the infrared. Oh no, oh yes.
Yeah.
Right now.
The previous one is in the right eye, Arnaldo. Yes.
Yeah. One more, yes, one more.
It's not,
This is not the.
Yeah, it's.
and that's the infrared, but here I'm, yeah, here
Yeah,
I'm
probably.
the infrared.
No, the outdoor.
Yes.
Yeah, yeah, the
Okay.
autofluorescence.
No,
That's from
That's
the next, from the left eye.
no, one more, it's one more.
I've mistakenly called this.
No, okay, no problem. One more.
autofluorescence of the
That's
retina.
okay.
The
Pra frente, pra frente. É.
The fringe?
yeah, the previous one.
Aí,
Yes, yes. So we can see that there is a a halo of hyper autofluorescence. So probably this is a hyper-reflective material similar to the vitelliform material in this case. That explain that hyper-reflective area in the OCT.
but on these autofluorescence, you have just the ring, the hyper autofluorescence ring. And the material is the subfocal area. So I agree with Professor Michel that it might be fiber. So do you have any serology?
Yeah, we did her blood work. It was negative for serologies. Also, she has normal leukocyte count, normal platelets, her HIV, syphilis, toxo, all negative.
Any inflammatory test?
Yeah, her PCR was kind of elevated, but her VHS wasn't. So we couldn't like exclude the other hypotheses only based on this elevated protein C.
Did you try any TB test?
Yeah, her tuberculin TST was negative.
Results in slides.
No, on the slides, no. Only I'm sorry for that. I only just to make us more.
He didn't do anything.
He's making the results up.
Yeah, just from his mind. Just gonna check the exams now.
That's terrific.
Give me her name.
Hey, Arnaldo, another thing that could confirm the diagnosis of MFC, the multifocal choroiditis, is because there are lesions, these lesions nasally to the optic disc. This is very common in choroiditis, in multifocal choroiditis. So this is another signal that it could be MFC.
So, of course, we are going to treat this patient. So the question is, we are going to treat with anti-VEGF. And would you do a laser on the non-perfusion area? No.
So is the non-perfusion area causing any problems?
No, it's not at all. It's expensive. And
Yeah, so just leave it alone and observe.
Yeah,
Did you keep it?
Yeah, we indicated the anti-VEGF injections, but sadly, I don't have her follow-up after the injections, but we didn't indicate any laser on the non-perfusion areas.
Great.
So you didn't indicate laser is not.
No, we didn't do.
Perfect. Thank you.
Thank you.
Yeah, I'd like to thank Dr. Carsten for being with us this week and the next week also. So it's a pleasure to have you here. Thank you.